like this.
Hi.
This microphone's on.
Good morning. Good morning, everyone. We're going to get started with Convene 2024. Good morning. We are going to get started with our conference, and our Dean, Jamie Prankert, will get us started. Thank you, Jamie.
Thank you. So good morning. As Pinar said, I'm Jamie Prankert, and I'm the Dean of the Carlson School of Management. And it is my pleasure to welcome you and thank you for joining for the 6th Annual Convene Conference. We're pleased once again to be able to offer the conference in a hybrid format. It is an incredibly important conference with important conversations, and so that allows health sector enthusiasts from anywhere beyond the Twin Cities to also join along and have their part in these important conversations. But I want to welcome all of you who are here in the room in the Carlson School, as well as those who are joining online from all over the world. This annual conference is hosted by the Business Advancement Center for Health, also known as BAC. And BAC was launched in January of 2022 with the vision to create a healthcare system that delivers equitable care to all individuals. And they do that by designing business-driven innovations that address gaps in health equity and by convening conversations to improve the value of healthcare among academic, industry, and community stakeholders. So BAC evolved out of the Carlson School's research and outreach efforts in healthcare, including the award-winning COVID-19 hospitalization tracking project that was led by the founding director of BAC, Professor Pinar Karacha-Mandich, as well as colleagues like Soumya Sen and Arkel, who is a great friend of the Carlson School, and we thank you for being here today. So BAC continues to show how to use business as a force for good to make healthcare equitable and accessible for all. For instance, Pinar is also leading research on a research grant to reimagine how healthcare funding works through a the creation and development of a tool called a social bond. And so on that foundation, today, you all have the unique opportunity to help advance a vision for making our Minnesota community a national hub for smart medical technologies, leveraging AI, machine learning, as well as state-of-the-art data analytic advances. And so Bach proudly presents this along with the Carlson School, and I am proud to to open this conference on the theme of building the vision for smart tech for health. That is drawing inspiration from Minnesota's recent federal designation as a medical tech hub. During today's conference, you'll be able to hear about crucial partnerships needed, the intersection of smart technologies with electronic healthcare records, and strategies for bringing innovations to market, including how they are funded. The outstanding lineup of experts we have here from the healthcare industry are going to be able to shed light on those and other important issues, and how Minnesota's pioneering role in smart tech advancements can move us forward and help us understand the challenges and opportunities that innovation faces. So I want to offer my thank you to the speakers, to the steering committee, to the Bach team, and everyone for making this possible and bringing us together to learn how we can support state-of-the-art and a statewide effort to successfully implement the vision of Minnesota as of the MedTech 3.0 hub. I also want to say that that events like this don't come together in a place like this without the work of a number of people behind the scenes, our building services people, caterers, our wonderful custodial staff. And so I just want to start out by thanking everyone who helps make something, an event like this possible. And I'm really proud of the work that happens here at the Carlson School to welcome in all of us to be able to convene conversations like this. And with that, I want to turn things over now to Pinar to send us forward and welcome, and again, welcome all of you and say, have a wonderful day. I'm really looking forward to it. Thank you so much.
Thank you, Jamie. For these wonderful opening remarks. And so, as Dean Prankert highlighted, the inception of Bach really stemmed from the healthcare research and outreach initiatives at the Carlson School with many of my collaborators here. And our dedication really lies in pioneering and reconceptualizing some of the very complex issues and their resolutions with a commitment to enhancing value and equity in healthcare. And we acknowledge that this endeavor cannot be undertaken single-handedly, neither by an academic institution alone, nor a business school, and it really strongly necessitates the collective efforts of all individuals present here today. And our purpose is to fearlessly delve into the crossroads of diverse disciplines of stakeholders, facilitating that mutual understanding and collaboration to address challenges and devise innovative solutions, which is what we need in healthcare. And this is why we're here today, and thank you for all being part of Convene 2024. And in addition to hosting and organizing events like Convene or our fall Health Sector Leaders Consortium, various other seminars and forums that we do at the school, we also train our students to work on those intersections of across disciplines for improving healthcare. Bach recently hosted the University of Minnesota Interdisciplinary Health Data Competition, which we do annually since 2020. And this year we had about 20 interdisciplinary teams. Each team had to represent multiple schools, that's the requirement, and 20 teams of students representing 12 different University of Minnesota colleges and schools. And the challenge and the task we gave them was not easy. What they did was they analyzed data from Minnesota Department of Health's all payer claims data public use files. And they looked at really interesting issues on healthcare utilization, costs, and healthcare disparities in our state. And so we're very, very extremely proud of the accomplishment of all the participating students. So, sixth annual Convene conference, and this year's theme, as Jamie mentioned, is building the vision for smart tech for health. And so you may be like, why this theme? And you gave a little bit of the prelude, Jamie, thank you. But basically every year when we prepare for Convene, we have extensive conversations with the community, and we solicit ideas and receive feedback on areas Convene could really explore that year. It was around October, and we saw this headline in the Twin Cities Business. And the headline said, Minnesota is named Federal Tech Hub. What now? And so that was it for us, right? That's it. That was what we wanted to look at it. So in a bid led by the greater MSP, and you will hear from them today as well, more than 20 Minnesota organizations collaborated on a proposal called the Minnesota MedTech 3.0, focusing primarily on AI, machine learning, and data science-powered medical technologies, referred to as the smart tech. And the result was that the Minnesota's bid was selected as one of the 31 hubs across the nation by the federal government. And so exciting. And now with over 200 and almost 250 teammates, I believe, and I'm personally honored to have a tiny little bit of contribution participating as a reviewer in the phase 2 part of the proposal that the MedTech Coalition drafted. We are honored to have such a unique opportunity through Convene to help advance a very bold vision in our region, right? Making our state the global hub for smart medical technologies and with state-of-the-art AI, machine learning, and data analytics. The vision is very big, and the potential impact is unquestionably tremendous. And these are medical technologies that allow for personalized, precise, tailored treatments, technologies that are effective in improving health outcomes, that are safe and scalable, and substantial advancements in innovation speed, revolutionize healthcare results, and fostering, very importantly, inclusive economic growth and expansion in our area, in our region. So it will take a dream team of collaborating organizations and individuals, and a careful strategy and flawless execution, and I'm confident we have that in our state. It will require strong partnerships of multiple stakeholders in our fragmented, yet we all know, very interdependent healthcare sector. And so today at Convene, let's explore all of that. Crucial partnerships, crucial ideas to scale, crucial ways to integrate, and crucial ways to help our economic growth. Our lineup is amazing, as you know, and I thank our speakers very much for being here. And I thank all of you, our audience. We are certain that the discussions and the collaborations today will take us to in that vision to build the global hub for smart tech for health. And I would like to take a moment to recognize our sponsors. Without them, none of this will be available and possible. So our distinction sponsors, University of Minnesota Data Science Initiative and Research Computing, our university community sponsor, Office of Academic Clinical Affairs, and our community sponsors, Minnesota Council of Health Plans and Medical Alley. Thank you so much. And our steering committee, always fantastic, Dr. Arkel Giorgio, Jitesh Tank, our MBA students who are in the committee, Joe Solinsky, Kalyan Fricke, Sarah Johnson, and Via Rao, and our program manager, Becky Strello. Becky, can please everyone see you, because you are the magic that made it possible, and thank you so much. I'm just so honored to be working with you. Thank you, Becky. And all our volunteers who are here today. And now, my great pleasure to introduce our moderator for the conference, Dr. Arkel Giorgio, who's a great friend and a collaborator, and as Jamie said, such an amazing friend and a contributor to our school here. Dr. Arkel Giorgio is one of the co-founders of Convene Conference back in 2018, when we launched the conference, and she has been participating and with her amazing time and contributions every year since then. And we are grateful for Dr. Giorgio for her outstanding work at the school, also through her role as an executive in residence in our Medical Industry Leadership Institute program, and years of support working in our convening industry executives and coaching our students and alumni, and selflessly dedicating your hours for mentoring our students and student teams who won many case competitions, and some of the students are here today too. And she has years of executive experience, including Chief Medical Officer at United, as Chief Health Officer at Starkey Hearing Technologies, and currently leading Giorgio Consulting. And she's also the immediate past chair of the Board of Director at Children's Hospital, Minnesota. She is an healthcare advocate, and her mission is to simplify complex healthcare information for consumers and passionately empower healthcare consumers to advocate for their health. And she has done it through many different ways. She's done it through her book, Healthcare Choices, and 5 Steps to Getting the Medical Care You Want and Need. Through her weekly segments at KSTV, she has produced over 2,000 segments over the past 16 years. And now her incredible podcast, Speak Up for Your Health, where she has deep and insightful and intimate conversations with individuals about how they navigated their healthcare journey. So thank you so much, Arkel, for joining us again, moderating our conference. And thank you, all of you.
Thank you so much. Pinar, you promised me that you would not read that bio. You broke your promise, but thank you very much. Really appreciate that. And I really appreciate the opportunity to do so much with the Carlson School. I've actually been involved with the Carlson School. This is my 10th year, as Pinar said, the last 6 years with Convene, with so many incredible experiences. And I think what I appreciate most about working with Carlson and the university in general is that the primary theme of everything we do, or the directive, is to have intellectual integrity. And while business, while lots of other issues are important as well, at the top of the list is the intellectual integrity that comes to the top of the list. And that's what makes it so fun and exciting, and that's how we learn. And that's why I like Convene, because we have the permission to have that intellectual integrity by asking our speakers tough questions, and by having you ask what's really on your mind. So I would really encourage you to do that all of today. We have incredible experienced speakers that have a wealth of knowledge to share with you, and I hope that you take advantage of what they have to offer. The way that our day will play out, as you could see from the agenda, is that we're going to start with the end in mind. So what does supporting successful innovation look like? And that's what our keynote speaker, who I'll introduce in a moment, will address. But then we're going to back up a little bit, and we're going to talk about what the background is to the greater MSP bid to making Minnesota a healthcare hub. And I recently read that whether or not we get all that federal funding or not, it's about $60 million in funding that we're eligible for. We are going to move forward as a state regardless. And if we get the funding, then all the better. But what does it mean? What's the background? How did it start? And what is more detail around the vision for that? And then we're going to go one step further, and we're going to talk about what it will take to successfully execute on that vision, and how do we have partnerships that establish that. And then, of course, all businesses depend on scale. And so what does it take to achieve that? And then finally, my favorite topic, and it's not because I'm moderating it, but because I think it's the most important, is how do we achieve a meaningful difference in people's lives with all of this smart tech that we're achieving? And so at the end of our day, we'll have a panel that will address that. So I hope that the agenda makes sense for you, that it unfolds in a way that you get inspired to think about how you're going to contribute to our state being a healthcare hub, and that you have some great takeaways. So with that, I'd like to introduce our keynote speaker, who is Dawn Owens. Dawn is the CEO of TT Capital Partners. It's a private equity firm that exclusively invests in healthcare companies. They have 18 companies in their portfolio, and they've had 8 successful exits. And That's why we thought it would be so incredible for Dawn to be our keynote speaker, because she has to scan the entire landscape of what's happening in healthcare in order to decide what few companies are going to get those precious dollars that they're going to invest in. So it's beyond what's really cool and what's really interesting, but she also, with her whole team, has to decide what is going to make a meaningful difference and what has the foundation to scale, so that it is successful as a larger business. So that lens is really important with respect to what we need to think about as we think about Minnesota being a healthcare hub. Prior to her role at TT Capital Partners, Dawn was at United Health Group, and that's where we met. We were both there for 15 years. 12 of those years, I believe, we were overlapping, and we worked so closely together on a number of things, including Dawn was overseeing a division that at that time was responsible for managing all of United's self-insured relationships, self-insured company relationships, the companies like the Deltas and the Johnson & Johnsons. And so she led that division, and I hopefully contributed a bit to demonstrating how we as an organization added value clinically, financially to their success. So we worked together really closely. The theme was always value. For a brief period of time, Dawn was also my boss, and I just want to publicly thank you for how gracious you were during that entire time. And so with that, I would like to introduce Dawn Owens as our keynote speaker.
Good morning, everyone. It's great to be here. Thank you, Arkel. We had some fun times and late nights together. I am really excited about this discussion and this whole day because, you know, how I would say timely is a discussion today, this moment in time, as it relates to smart tech and innovation. Everybody's talking about it. I've been, since I agreed to do this keynote, I've probably gone to 3 very significant conferences, most of them being executive conferences, health plan CEOs, health system CEOs, chief technology officers, et cetera, and everyone is talking about this topic. And candidly, I would say nobody's gotten it nailed yet, right? Everybody's trying to figure out, where am I going to prioritize? Where am I going to focus? What does success look like? And what I so appreciate as I've gotten to know what you're doing here with Convene, what you're doing at the Carlson School, is how you bring together all the voices as it relates to that dialogue, right? It's not just one silo or another, but bringing together the ecosystem to say, what do we want to achieve? How are we going to get there, and what does it take to deliver on that? And so that's what I hope to kind of set the stage for in my discussion today. This topic, smart tech, AI, machine learning, all of those things, and the role of innovation is super broad. So I'm not going to cover everything, so don't expect me to tell you all you need to know, but I am going to cover it based upon what I do and what my experience has been, which is largely focused in the business process outsource services arena around healthcare technology and healthcare services businesses. So the businesses I've been a part of leading in my United Health Group context, as well as the businesses that I'm investing in, are businesses that serve the healthcare ecosystem. They work with health systems, they work with medical groups, they work with health plans and payers, they work with the government and all aspects. So that's the perspective that I bring to this conversation, and that I hope is one that is helpful as we kick things off. I fundamentally believe that innovation is not an end in and of itself. It's a way to accomplish our goals, to address the challenges, to address the priorities of the system. So as we go through this discussion, I'm going to spend a lot of time on, like, what are the big things we need to be paying attention to? Now, it's not, again, going to be comprehensive, but it is the stuff that I spend a lot of time focusing on, because it's in those things that we can understand where innovation is necessary, where financing can become unlocked and available, and where there is a catalyst for change and opportunity and momentum. And as I looked at the entire day from an agenda perspective, I think, again, we'll pass through those gates around how we explore together what that looks like for our community and certainly for our overall healthcare economy. Yeah, I love this picture because to me, when I think about the opportunity for smart tech, as I think about AI, I think about all the possibilities. And I would say I come into today's discussion probably more optimistic and enthusiastic than I was when I kind of took on this assignment, when we had our initial conversation about it, because I really do think that it is, that we will experience in our lifetime a tremendous degree of change. But at the same time, we actually don't have a very good track record in healthcare, right? So while AI and smart tech can accelerate and improve clinical discovery, it can help providers, nurses, physicians make better decisions, more timely decisions, engage with patients in a different way. While it can get after, and I'm sure we're going to talk about this, the massive paperwork and administrivia that our healthcare system is saddled with, the reality is even really good ideas, things that are uncontroversial, take a long time to adopt. So I think it's actually not inappropriate to start with the EHR. I know we're going to talk about it today, but 2000, and well, no, it's not even 2000. It was in 1991, the IOM report around this is an essential tool and utility. A year later, they said, we need to shift our system from paper to digital. And then over 12 years later, I think it's 15 years later, we still only had a fraction, 2% of the hospitals and 4% of the physician practices actually using a meaningful EHR. That is slow progress, right? Now, there are really good reasons for that slow progress. It was daunting. You had to, I mean, one, people didn't want to give up their paper, and how many of you still have your paper? Not your paper medical records, but paper in other parts of your lives where there are digital substitutes that actually are much more efficient and effective, but that's okay. But, you know, the real reasons why it took so long was it was a huge investment, and it just wasn't an investment of dollars, but it was an investment of productivity. It was an investment of changing workflows. It was a change management journey that we as an industry weren't prepared for. And it took, in 2009 and 10, federal action that said, you know what, this is a priority. So with the high-tech act that came into the American Recovery blah, blah, blah Act, the funding became available to create incentives for our system to adopt the EHR. But it was only until those incentives were going to expire and when the penalties were going to come into place for not using them is when the system started to take action. And so the question I want to ask all of us and that I want to kind of talk through today is it going to be any different this time around as it relates to the innovation that presents itself? And what is it that makes the difference and what actually creates that change? So actually, I'm going to go back. So the market forces shaping healthcare. I've talked about this already, but I think innovation for innovation's sake, my experience, generally doesn't get much traction. There are lots of really cool things in the market. I love folks coming from outside of healthcare who have really innovative, thoughtful ideas of what they can do to make our healthcare system better. However, they don't understand our healthcare system. They don't understand the financial priorities and complexities. They don't understand the, how it operates on most dimensions. And as a result, they don't have financial, business, and other models that allow those cool ideas to actually get traction and scale. So I think it's really important to understand and kind of align around some key things that are really important that we're paying attention to. And that's the purpose of this section here. I think the other thing I would say is, especially as it relates to AI in and of itself is not a strategy. Smart tech is not a strategy. A strategy is to improve the healthcare in our community. A strategy is to address the inequities that exist in the way in which our healthcare system operates. A strategy is to get after costs and waste and opportunity to improve outcomes. And so that's what we're going to talk about. So first and foremost, we all know, you're like, what? Okay, everybody starts a presentation around how much healthcare costs. But the reality is it costs a ton. And I think at some point we all get desensitized. I know I get desensitized to the magnitude of the cost of healthcare in our system. And I thought it would actually be helpful to see it relative to what it looked like in 1970, which is, well, for those of you students, it's not within your lifetime. It is within my lifetime. And I think there are some really important things that kind of popped out to me as I looked at the cost equation through this lens. $2,100 per capita spending, per person spending, versus over $13,000, right? It's huge. I was doing the math around like, what's the percentage increase? I can't even calculate it, right? But it's an 8% compounded growth rate over that period of time. What I think is really telling, look at that first line, out-of-pocket costs. Out-of-pocket costs is what we pay for healthcare. By the way, it does not include our premiums. So it doesn't include your cost sharing on the premium. It's only your co-insurance, your copay, your non-covered expenses that you're funding on your own. And it's kind of, my first thought was, what's everybody complaining about? We're actually paying less as a percentage of the total healthcare dollar than we did in 1970. 10% versus 32%. But look at those real dollars, right? I mean, it's huge. 18% of today's median income is going to fund the out-of-pocket costs for healthcare, and that doesn't include your premium. No wonder the consumers are frustrated. No wonder they're afraid of medical cost bankruptcy. It's real. And so I think it's been I think it's an insightful way. Look at that public health insurance line. That's our entitlement programs, Medicare, Medicaid, the veterans coverage, all really important things. But we're spending more in that category at the federal level than we do on defense. We spend less than $1 trillion on defense, and we're spending $1.9 trillion as it relates to healthcare in our public health insurance programs. So it's big. And it is at a point for us, honestly, since I started in this industry, it's like, we can't afford it, it's too big of a percentage of GDP, it's unsustainable. I really think we're getting to that point where it's like, it really is. And if you look at, and I'm not gonna talk about today, the innovations around plan designs and offerings in the employer market segment, I think it tells a story about the employer community and the consumer community trying to grapple with, like, how do I fund this? How does this financial equation work? And we got to figure it out. And I think it's a big motivator for us around how we set the priorities. Now, so we spend $4.5 trillion on healthcare, And 25% of that cost is administrative. That's paying claims, that's checking eligibility, that's fighting with each other about how much things are going to get paid. It's the process that we all go through as patients in healthcare, where every time I go in, I have to fill out the same paper forms. I need to have the same, I then need to repeat that same information to my physician and do it all over again with the specialists that I get referred to, et cetera, et cetera, et cetera. Because our healthcare economy is a cottage industry. It's silos, it's pieces, parts. And while we've made progress around those pieces, parts, it's not interconnected. And it makes things really difficult. It makes things difficult for people who provide care. It makes things difficult for people who receive care. And McKinsey did a really interesting study I was reading as I was preparing for this. 25%, or actually 28% of the $1.1 trillion of administrative costs they think is wasteful and that we can get after and take out of the system. So it's not good, there's a lot of waste in healthcare, not just on administration, but if you had to choose where you're gonna put your money, you'd rather put more money into clinical care versus administrative, and there's great, ripe opportunities to take cost out of the system. And I do think smart tech and AI is a really important ingredient to getting after that cost. But it's not just costly, it's fragmented, it's complex, and it's old. HIMSS recently published a piece of work looking at the public health system across our country and saying, listen, this picture applies to that as well. And it's not it does not have the technical backbone to be able to weather health crises, to connect with one another, to understand data, et cetera. In fact, 83% of all of software is outdated that networks into our healthcare economy today. Huge, huge problem. And so in that, in the work that HIMSS put together, they recommended spending $37 billion over the next 10 years to fix the public health technical backbone, because it's such an important ingredient to health, certainly to health equity in our country, and it is not set up for success. So, costs are big, there's waste in the system, we gotta get after it, and we're doing that in a context where the way in which the resources that are available to care for the population and the demands on that population are increasingly separating. The demand and the need of our system is increasingly far outstripping the capacity that we have to serve that need. And that is made up of a lot of different things, but to way oversimplify it, we are getting older. 10,000 people per day are now eligible for Medicare. So we are just increasingly marching down a very large average age increase for our country. Obviously, as we age, we get, our health begins to deteriorate. But it's not just, I love this term, the silver tsunami, but it's also the gaps that we have around these care deserts, about access to care issues, about healthcare equity issues. And that also puts new demands and increasing demands on our system. Deloitte did a study as to what's the cost of healthcare inequities annually to our country, and they estimated it today to be at about $320 billion. By 2040, if we don't do something about it, they estimate that cost to be over $1 trillion, right? So this is real. What you guys are talking about and discussing is real. But that is on top of a healthcare system that post-COVID is just really struggling, right? We lost 3.2 million workers, or we're short we need 3.2 million workers. We lost 1 in 5 healthcare workers during the pandemic. As we look out to the future, we need 300,000 more providers, 120,000 more physicians, and 200,000 nurses. The burnout rate is high. Arkel and I were having a conversation before we started. She was sharing about her husband, David, who's a practicing physician, and what it is when he comes home. And his day being intense and then being filled after hours with all the paperwork that he needs to do as a part of his practice. That's not sustainable. We've got to address it. There was one study talking about the mountain of new innovations, technologies, therapies that are coming to bear, and what it is for physicians to keep up on the new standards, the new opportunities, et cetera. And they calculated that if you're gonna practice evidence-based medicine, you needed 27 hours per day to do it. Like, we can't do that. We've got to find a different way to solve for this. And the final point I'll make around context is that the market is shifting the way it pays for healthcare. Now, you might say, that's a really odd one to put in here. But I don't think it's odd, because what is the shift away from fee-for-service healthcare to shift for value? At the end of the day, oversimplify, I look at it as we are going to begin to create a financial system that pays for performance, that actually encourages health, not just a system that provides for sick care, that rewards and allows the system to participate when we're doing better things clinically and operationally for our patients from a quality perspective, and we're doing it more efficiently. And that can create, I believe, an economic opportunity for our healthcare system to actually benefit from some of the changes that we have the opportunity to make with the way in which care gets delivered, the way in which we transact together, the way in which things are organized, the way in which we amplify, not take away from, what our clinicians are doing today. And I think that creates a platform for change that's going to be really important as we think about addressing these other challenges and leveraging smart technology to accomplish that. And so I hope you ask questions on that. I'd love to take them. And listen, we got a long way on that journey, right? This is it, whether you agree with it or not, the shift of value is happening. Our federal government is the single largest payer in healthcare. They have said by 2030, they want 100% of their beneficiaries in value-based relationships. What that means as it relates to the chart on the bottom of this page is that they have to be on the far right of that spectrum. And it's not just the last two, it's like a quarter of the third box and 100% of that population health box. That's a huge undertaking. Will they hit that objective? Who knows? It's the right kind of aiming point, so it's coming. So let's figure out how we use that to our benefit to drive change and innovation within our healthcare system. So what are the near-term opportunities as it relates to healthcare smart tech? And I approached this part of the discussion a couple different ways. First off, I want to look at something outside of the healthcare industry that I think can be very informative to all of us as we're thinking about innovation and what it took to, I would say, deliver innovation, again, in another context. And then we'll kind of follow the trail that case study lays out to then dive into some specific opportunities that I imagine you're going to hear a lot more about as we go throughout the day. So I picked the ATM. I thought about a lot of different technologies and innovations, but I picked the ATM, and I think it's a perfect example to help shed light on what does innovation look like in this next horizon of time. So I didn't realize this. I mean, the ATM was first invented in 1967 in London. And as you can see from the chart on the bottom, the adoption actually took some time to get to. Now, what's interesting, and I'm sure everybody's heard it, right? Like, no consumer ever asked for an ATM. ATMs didn't get developed because consumers were asking for ATMs. That is true. But actually knowing why they got developed is actually a really interesting story that I think, again, can be informative for us in this discussion today. At that time, in the United States, in the late 60s, early 70s, 30% of Americans did not have bank accounts. They didn't have bank accounts because they got paid. They were factory workers, a lot of them. They got paid cash. They took their cash. They paid their bills. There wasn't that much left over. What's the point of a bank? On top of that, the bank was only open when I'm working. So I couldn't actually use the bank because it didn't meet my needs. It didn't provide a service that was relevant to my equation. And so the industry was getting a lot of pressure over time to like open up new branches, extend hours, all the things that they didn't want to do because they, for probably a less profitable client base, and they started to explore other ways to serve the needs. What's interesting is when the ATMs initially were introduced, they were like, has anybody here experienced the early days of the really early days of the ATM? Did you know that they used, did you use tokens? I didn't, so when they were first introduced, we have our ATM, our debit cards, that wasn't the thing. It was, you got tokens to put into the ATM that you got from the bank teller that you could use to get your money out in predetermined amounts. It was only available to dispense when the bank was actually open. Kind of sound like the healthcare, right? System, you gotta be able to kind of get the window when the services are available to get the service. Because at the time it was introduced, the marketplace was not digitized, there were no common standards, you couldn't use them the way we use them today, which we take so for granted. I can be in London, I can be in Hong Kong, I can be in New York, and I can access my bank account, I can do all sorts of things. And it was that journey of innovation, which, by the way, required industry collaboration, which required industry standardization, which required the digitization of the financial networks. And it not only accelerated the use of the ATM, but it also spawned all sorts of innovation and offshoots of capabilities and products in the financial services industry at the retail level. And I think that's really informative to us. On top of that, what I found interesting as I was doing reading on this, consumers didn't want to use it. The industry actually created all sorts of incentives like raffle prizes and door prizes like for people to use it because people just weren't using it. But until the industry, those incentives, by the way, didn't work. What did work is actually making them convenient. What did work is networking them. What did work was having the small banks as well as the large banks be able to provide for them. And again, I think really important things for us to think about as we think about how innovation, how we have a different experience with innovation in healthcare, or whether there's an opportunity to do that. So because I think the ATM story tells us that we need to understand whether the market's ready, what that looks like as we innovate, we're gonna go through a couple things looking at, are we ready? So we're gonna look at through the lens of hospitals and health systems, physicians and clinical, in the category in general, and then finally consumers. And what did they say? And the question was around AI, right? Like what's your view of AI? So this is from a survey from the advisory board that they went out to healthcare technology leaders within health systems, and they said, what are you trying to solve? What problem are you trying to solve for AI? What do you want to work on? And no surprise, the biggest things they want to do are to optimize their clinical workflows and minimize the burnout and the workforce challenges, right? Go back to those problems that we're trying to solve. Other things are important, but everything pales in comparison to the workforce and to get after the workforce, the clinical workflows, right? Like, we got to get after that. Furthermore, when they were asked, well, are you ready? And I have to say, I saw this in some of these conferences I've been in. And while we can be really encouraged by 52% said somewhat ready, that's not a really like gung-ho, like I'm ready. Only 7% are really ready. You know, you've got a very large portion of the market that's like, yeah, I'm not so sure. And I certainly heard from CEOs and other leaders at the health system level in a recent conference that I was a part of, asking some very fundamental questions that would suggest that they have yet to form a plan, that they are curious, they are optimistic, but they don't know where to start, and they don't know how to prioritize. And you know, I can understand that. It's but I think you're going to hear that there's help is on the way. From a physician perspective, bring it on, right? We're ready is really what this slide says. And this looks at both generative AI and just AI in general. I think this is a Wolters Kluwer survey of physicians. I would say the focus was more on generative AI versus AI more broadly. But you know, I would say what you don't see here is like, well, I don't know, it's trustworthy. Well, I'm really worried about accuracy. I think it's like, I think it can help, and I think it can help in meaningful ways. Now, I think this bottom part here is a really important piece, because they also are telling us what has to be in place for generative AI to be effective from their standpoint, right? So they need to know that this is really trustworthy. You can't just tell me an answer. You got to tell me, like, why? Where's that answer coming from? You need to be able to say the credibility of that answer. You need to, they want to work with trusted companies. Now, when I go through some of these examples, you're gonna see, yeah, I don't know if you've ever heard of any of these companies, right? So which is really interesting, right? You see the traditional players in the marketplace, technology and healthcare technology, as well as just new. So the big guys, but you also see these private companies, earlier stage companies in this space. But physicians are ready. They're excited. They really feel like it can help them, help their clinical teams, help their patients. But, you know, it's got to be real and it's got to be credible. But maybe not everybody's on the same page. This was from yesterday, or 2 days ago, from the San Francisco Chronicle. And candidly, I don't know the details of what instigated this particular protest, but I think it's a good reminder to us all, like, change management really matters. I really genuinely don't believe that the opportunity in healthcare today is to take away or to replace people, whether those be nurses, whether those be physicians. You look at 300,000 people, clinicians that we need now or very shortly. We need all the people we have and more, and we need them to be able to do their job, which is treating patients, caring for patients. But this is a change management issue. This is a communication issue. I don't know that it is, but that's my guess. And it's a really important element of what we need to focus on as we embark upon this change. And then actually, you know, you think about it, the broad marketplace of consumers are very tech savvy. They're very open to adoption, but they're not so sure about this AI thing as it relates to healthcare. They are more focused on, you know, they are worried. They're uncomfortable with you, if you're a physician, relying upon AI. They're worried that we as a marketplace are going to move too fast before we really understand the implications of it. Now, they do think that it's going to reduce, I think it's ironic, they do think it's going to reduce medical errors. There's also some information in this survey. This survey was a very broad 10,000 people survey from the Pew Foundation. These Americans do think that it can help improve quality. They do think it can help improve access. And they do use it, but not as much as you would think, right? So I think, you know, again, you've got a mixed marketplace. So let's go into the examples. And I'm going to touch on these at a pretty high level because I know Arkel wants to make sure that we have time for some questions too. But I have 3 pages on this. And let me just share with you how I organized it. Again, this is organized around some of the pain points that we can solve using smart technology and AI. It goes from, I would say, I found a really helpful framework from McKinsey as I was doing some reading on this topic. And it was a topic of AI innovation and cost takeout. Or actually, it was on innovation and cost takeout in the healthcare system. And they had 3 categories of how to get after things. One category is within. You can do it all within your organization. You don't need to involve other stakeholders, really. You always have to involve the patient, but you can do it inside your own organization. This particular set of examples are within. It's focused on the healthcare workforce crisis. It's largely health system and hospital focused, although it can be applied into other categories. And the opportunity is you can do it inside your 4 walls, if you will, and get after it. So you control the decisions, the elements associated with it. The next is where collaboration is required. Best example of that is you need a payer and a provider together to agree on what it is you're trying to achieve, and each of them needs to do something. That's more difficult to do. That's why you guys are all here together, a cross-section of the industry. And then the third area is seismic. And I didn't put a seismic example. I did have one. I had this very cool video. But you know what? Honestly, I think it is so far out there, I wasn't sure that it would be a great use of our time. So addressing the clinical workforce, you know this, the problems. We've talked about them already today, but a few more to illuminate. 60%, as much of 60% of a clinician's time is spent in their EHR. That's when they're with patients quite often, but also before they see the patient, while they're seeing the patient, and then after they see the patient. So that's why it's such a big percentage. And I don't know, when you talk to your kids and they're on their technology, do you think they're paying attention to you? It's harder to listen well when you're on technology, even when you're taking notes. And that's what we've asked our clinical teams to do. But the opportunity, and I'd say this is, if I talked to a few luminaries at the advisory board to prepare for this discussion, and they called out 2 areas that they were most excited about as it relates to near-term opportunities for AI. And this first column is one of those areas. How do you leverage ambient listening tools and other resources to document that clinical episode and produce patient summaries, clinical notes, informed coding, all of which has to still be reviewed by the physician for accuracy, but can really accelerate and change the engagement between a physician and patient. I had the opportunity to sit down next to the founder of one of these companies, actually not one that is mentioned here, and he and I did a patient-physician visit. And and I actually told him about he's a physician. So we went through the dialogue, and he was using the technology. It was amazing to see the clinical precision, the accuracy of the capture, and then how that, like right there in the hotel lobby, was translated into a patient summary, a clinical note, whatever else needed to be done. So it was super impressive and very enthusiastic. And these are just some companies that are doing activities in these areas. I think the offshoots of this are massive. I know for our portfolio of investments, those investments that we have that are actually in the clinical care delivery area, we don't do that. We really don't invest much in that category, but we have a few. And we are very much looking and evaluating these technologies because it is such a challenging area from a workforce perspective for us. The second area, I think, of opportunity that I just wanted to call out, very different. So that one is more again, it's really getting after the paper, the attention, the administrivia that clinicians need to deal with. And frankly, it's not just filling out the reports, it's like preparing for the visit, and it's focusing on the right thing, and it's having a true, intelligent history that allows you to focus in the right places. The other one that I've been really interested in, been following pretty closely is, the medical grade wearables in at the bedside. And this company that I'm using it as an example, I think some of you might know them who are in the room. But they are, this is broad scale, broadly deployed. Houston Methodist has deployed it in every single hospital bed across their health system so that they can do almost real-time continuous monitoring. And think about the implications of that. The nurse doesn't need to wake you up to take a blood pressure, to check your temperature, to look at your pulse ox. The ability to see adverse results and use data and data science to understand if a patient is deteriorating, whether that patient is in the home setting or in the hospital setting. So it frees up, it provides better surveillance and insights, and it creates actionable opportunities that can really address errors, improve outcomes, and so forth. So super exciting opportunity there. And one step further from that is this whole invisibles market. Anybody, the invisibles market is where you don't even have something on you, but your environment is being monitored, and you can understand a person by different sensors and how they're doing, used and applied today in clinical trials, but can be applied in assisted living homes, et cetera, ways to monitor the seniors in home, in place, without being obtrusive. Second category is, so that first category is primarily, our example is focused on the health and hospital system environment. This is more of I'm gonna call it a utility. And it's a utility that can be used for payers, for providers, for payviders, for pharma, et cetera. And it's unlocking 60% of the data that's in the EHR that is not codified, right? The EHR has a huge amount of clinical notes. It's rich of data and information about the patient, their history, their family, et cetera. And very little of that is captured today. And as you can imagine, since it's input by the clinician, the variability of how that information is input is all over the map. But the cool thing is that, and these are just two examples of companies, there are many more, who can take that clinical data, medically graded, extract it, they're enterprise solutions that extract that data so that it can be usable. So that it can be usable in the clinical setting, so that it can be usable for payers to understand their populations, so that it can be usable to support prior authorizations or revenue cycle. The use cases are endless. And this is an area where there is a lot of adoption and utilization, but it's also a good example of an area that took a while to get traction, both because the technology needed to be or has been, I would say, even more refined. And this is one where the customer, whether it's the health system or the payer, needs to know how to use it and apply it within their environment. So it's more of a enterprise tech solution capability that end market needs to know how to consume. But this is one, again, I could go on and on about the opportunities that exist here. And then finally, this is a category, when I asked that luminary at the advisory board, what are you most excited about in the near term of AI? He talked about the clinical workforce side of things. And then he mentioned this item, which is prior authorizations. Now, prior authorization is when you have to ask for permission to have a clinical intervention paid for by the payer. And interestingly, 85% of the time, those things get approved. But even though they get approved most of the time, they still are a huge burden on the system. It requires a tremendous effort both by the provider to submit the information required, as well as the payer who has to take that submission, most of the time coming through on fax, yes, it is fax still, and manually review it against clinical guidelines, right? Arkel back in the day did a lot of innovation just to take some of that type of work out of the system by saying we don't need to do these things anymore. But they still exist and they're a prevalent part of the system. And so this is an area that requires for it to change, to move out of a manual environment, to move out of something that not only costs the system money, but delays care, right? Think about the patient who's like, I just want to have my whatever addressed. I feel like I'm a ticking time bomb. I want to receive my care now. And they're waiting on this process to sort itself out so that we can determine whether the system's going to pay for it or what alternatives the system will pay for. So from a payer perspective, there are vendors. These are a few that are mentioned. Most of these innovators are really serving the payer market, helping them codify their prior authorization policies and ingest the clinical data in such a way where they can at least automate a portion of the prior authorizations. But for this to succeed, providers have to do something other than submit via fax. But you know what? If you understood the way that the systems are set up for them to submit these requests to the payers, you'd say, I'd do a fax too. It's a lot easier. And so there's a lot of change there. Yeah, okay. I haven't seen any of your warnings. Okay, good. No, because I haven't, but you're doing great. I'm going long. So those are some of the areas of opportunity. So really quickly, as I think about this category, I do think that we need to prioritize where we focus our energies, our enthusiasm, and focus in on the priorities around innovation in healthcare. I am not representing that the 3 areas or 4 areas that I called out are the only areas, and I'm certainly not representing that those companies are the only companies doing things, right? So this is not, I'm not promoting any of that. But, smart tech does need to be smart business. It does need to have strong financial and go-to-market strategies. That's more for the innovators and the entities that are delivering smart tech. We've got to understand what it will take to succeed across the various constituencies. It's going to require, which is the beauty of this conference, cross-sector collaboration and cooperation. This is going to be a journey. It's going to be a really exciting one. I think it's going to make us all better. I'm proud to be here and be a part of that journey here in Minnesota here at Convene. So with that, I'm sorry I went long, Arkel. I didn't get a shepherd's crook, so that's good. But I think we're ready for Q&A. Oh, I have a great quote though. So this is a great way to end this. So I love this. Bill Gates, we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. So I think that's really appropriate, and it's a great way to conclude. That's it.
Thank you so much. Because some of our other speakers have a hard stop, we don't have time
Okay,
for
good.
Q
All
and A,
right.
but if you're going to be here, no,
Yeah.
no, you don't need to rush off, it's okay. So thank you so much. I was so happy about your optimism, and at the same time struck by the fact that there was one statistic that stood out to me, which is that we've been talking about value-based care since 2008 when the Affordable Care Act passed, and we're still only at 18%. And that suggests to me that yes, we can be optimistic, but adoption takes such a long time, and hopefully the technologies will evolve to speed up that adoption. So are you going to be around? Awesome. So you can ask Dawn some questions during some breaks. Thank you so much for your comments, for the stage setting. And what we're going to transition to is our next panel that is going to be led by Rick. Oh my goodness, I'm having a hard time with your last name. Help me with your last name. Hibsch. And so, Rick, I'm going to ask you and your panel to come up while we set up the chairs and then take over. You're going to introduce the panel as well as the topic. There you go.
Sure. Yeah. Yeah. No song and dance. I can chat here while we're getting started. Yeah. What a great setup. Thank you, Dawn, for that. And looks like we have a few people taking a bio break, so it'll give us a little time here to get set up. But what we want to chat about today is really the collaboration. And so. Maybe while these people are getting started, I can introduce a little bit about myself and the university. I think a lot of people know about the University of Minnesota as a place for education. We have 60,000 students and grant 15,000 degrees and all of those types of things. But universities have three basic missions. Education is one of those, but research and outreach are also two of the other missions today. So we can talk a little bit about that. Rick Hibsch, I'm the Associate VP of Research and focused on technology commercialization. The University of Minnesota is a research powerhouse. We have $1.2 billion a year in research. A portion of that does create some innovations, and those innovations are managed by our office. So we work with the researchers across the university to commercialize some of the technologies, and we average about 20 to 25 startups a year. That's one mechanism for commercialization. We've worked with Panara and her startup, Xanthos Health, and there's many other startups across the university. And we're very interested in being part of the ecosystem, and that's why today's panel is so interesting, is just being part of that whole collaborative effort. Our topic today for this panel, just get the title right here, Advancing Innovation Through Collaboration, and I think really that collaboration is the key message. As we just heard from our keynote speaker, there's lots of different types of innovation that can happen, and obviously you want to have innovation not for innovation's sake, but collaborative innovation is going to be an important part of this. And so today we have three parts of the ecosystem that are also participating. I'll have them introduce themselves in a second. But one of the backdrops for this is the Smart MedTech effort and Minnesota MedTech 3.0. And there are 200 and some partners involved in that effort. So maybe just by a quick show of hands, if you or your organization is one of those 260, raise your hand. So if your team is involved somehow in that Minnesota MedTech 3.0 effort, I know everybody on the panel is. Yeah, we got a few. And so we're not going to give a very broad definition of that, but certainly it is a very collaborative effort. One of the formative parts of that, and I'll let maybe Jim give a little bit of that history when he speaks, was based on a community effort, a very collaborative effort. But the most recent portion where we got the designation as being a MedTech hub actually came from the federal government, the Economic Development Association, EDA, and it was a grant process. It began by providing, putting together a grant proposal to get the designation, and then now competing with many other of the hubs. I think there were over 30 or 31 hubs. A small portion of those hubs will actually have the funding behind them, and so it's interesting. The University of Minnesota, as I said, we compete for grants all the time. We have a lot of people that can write grant applications. This in particular is much, much different, and it requires a different type of collaboration and you know, greater MSP, and we'll have Jim speak a little bit more about that, was the leading effort, but it really, for these types of economic development oriented or transformative and translation oriented grants, it does take a very much a team effort. And so again, I'll stop talking about myself here and just pass the baton here. We're going to have our three speakers each introduce themselves and a little bit about their organizations, maybe a couple minutes each, and then we'll go through some questions, and certainly I invite hopefully have some time for each of you to answer questions. So we talked about a designation as a MedTech hub, a smart MedTech hub, and maybe Bobby, as you're speaking, you can talk about the self-anointed designation that we all have here as a medical alley.
So you want me to use this? Or
You got it.
Is this working? That's okay, good. So hello, thanks for having me, and thanks for the conversation. It's going to be a fun one. And, you know, self-designation. So our designation of this community, how many of you heard of Medical Alley? Yay. We're celebrating our 40th year, and we're pretty proud of it. You know, we look at Medical Alley today, we're a global organization headquartered here. Okay. Oh, am I not on? Okay.
No worries, no worries. So, you know, we look at Medical Alley, we're a global organization, and we're headquartered here in Minnesota, and we have over 800, we're nearing 900 partners. And the cool part within that is we represent the entire ecosystem. So when you sit and think about the different sectors, I think of it in terms of a continuum of care and all the components that touch a patient. And I always talk about patients being our focus, because at the end of the day, there isn't one of us in this room that aren't a patient, or our families, or our friends. And so it all keeps coming back to that. And the vision for Medical Alley, when it was created 40 years ago, came from Earl Bakken of Medtronic, Lee Berlin of 3M, and today 3M Health is known as Solventum, launched just 3 weeks ago, right? And then it was our government, it was Governor Rudy Perpich, and their vision was to be the epicenter of health, innovation, and care. And the really neat part about that is that today with our board has been and remains the vision statement. While our mission has changed in 2022, it's about activating and amplifying healthcare transformation. But you think about those partners, and they're dedicated to that. They're dedicated to transforming healthcare on behalf of patient populations. So when we talk about Medical Alley, we're talking about the organization that is doing the work behind it. But we also talk about what we created, which is the place. And the place is where we live. We are the Silicon Valley of health. And one of the reasons we're excited about the Tech Hub work is because it's another way of showcasing. We know what happens on each coast, but this mid-sector, you'll find, actually has more healthcare going on than any other sector, particularly in med tech, and yet we're overshadowed. So that's who we are, and you are part of it. So when we talk about that network, many of you in the room are partners or affiliated with partners. In fact, I invite you, our biggest gathering of the year is our annual meeting. It's going to be May 16th at US Bank Stadium. And part of our work, when we were talking earlier, when Don was referencing, is health equity. So we are very committed to access and quality and affordability. And within that access piece, we are committed to reducing barriers for underserved populations to care. And our focus right now is one near and dear to all our hearts, which is mental health. So Brooke Shields will be speaking that evening. I don't know if you realize what her background is, but she's done a documentary, she's written books, and she's an entrepreneur, which you'll learn later in our panel discussion is very much what we're about with our STARTS program. So Medical Alley Pass, Medical Alley today. Thanks for having us, and thanks for being a part of the community.
Hey, thanks, Bobby. Dr. Cunningham, glad to have you here today representing the state of Minnesota. So if you could introduce yourself.
I'm Brooke Cunningham, representing the state. That sounds really heavy and big. But so Brooke Cunningham, I'm Commissioner of Health at the Minnesota Department of Health, which is our state's public health agency. As you all know, health is covered by multiple state agencies at the governmental level, so like representing the whole state. So Department of Human Service, which is our Medicaid agency, Direct Care, also sort of child health and coverage for vulnerable adults in Minnesota. Also Commerce, when we think of probably including the spaces that you all are in, MNSHORE, CGIP, which are our biggest sort of state employers. So there are a number of entities on the governmental side that address health and the care and well-being of Minnesotans. Clearly at the Minnesota Department of Health, our focus is really upstream. It's on prevention, it's on protecting, maintaining, and improving population health. And so the one thing, I moved to Minnesota in 2013 to do a postdoc. I'm trained as a physician and a sociologist. And when I came to the state, I was impressed, right? I did not know we were the Silicon Valley of health tech. Like, that's fantastic. I did not know that we had that status, so that's fantastic. But I had learned of a number of the big companies in the space, and with that, then coming and focusing on health equity, which is a core tenet of public health, has to be something everybody in this room does, right? Because as we are the Silicon Valley, as we come up in sort of national health statistics as having some of the best healthcare in the country, we're always like in the top 5. We have some of the worst disparities in the country. And I'll be honest, when I think about public health, I always think public health is actually low tech. So I look forward to you all telling me and talking to me and partnering with us to help really innovate in the health equity space. There are lots of population health needs. Accessibility is certainly one of those needs. And I also, as a physician, come in thinking about who I see in my practice. I work at the COOT Clinic, which is the Community University Healthcare Center. It sees folks on MA. It sees all the uninsured and underinsured Minnesotans. And a lot of my patients' challenges are really just getting their basic needs met. So those of you all who have a public health perspective and have seen that pie chart that is often showed whenever you enter a space that talks about public health, it talks about how health care or clinical care is only the slither that contributes to health outcomes. Everything else, like 80% is everything outside of health care. So what I would encourage us to do and talk about today is how can we come into community health as population health in addition to patient care. And think about that 80% and think about it from that tech space, because resources are tight. And the challenges are only getting more immense. And so I think when I think about how we can make things simpler for people, as well as healthcare providers, as well as payers, as well as those folks that we regulate. So MDH does a whole bunch of data. I think data will come up here probably. We convene groups together to talk about health priority issues, and we do regulation, right? And there's a lot of challenge sort of in that regulatory payment space, which is not patient-facing, but it is patient-impacting for sure in terms of the things that we are looking for to keep folks safe when they come into healthcare, and to keep us as a state being able to be a partner and to respond to in a timely fashion to concerns about folks' experiences, people's experiences when they go into to care. So I think there are a lot of spaces, and the last thing that I will bring up as we think about health, right, because I'm gonna come in as, right, the public health person, so talking a lot outside of just healthcare, let me just lift up water. So however water intersects with you all's portfolios around health, please think about that. And please think about how you might support community water systems, folks living on wells, those sorts of spaces. Clearly, that's been in the media. The EPA is taking increasing action to make sure our environmental health, we all have access to clean water, clean air. They are really pushing environmental health priorities. Clean water is critically important to people's well-being and health. And so I also invite that one space. I might not get an opportunity to talk about it again, so I'm going to lift it up here as we think about all of the broad factors that contribute to health. But I'm very happy to be here. Thank you.
Thank you, Dr. Cunningham, and especially thank you for broadening that definition. I think it's a very important observation that we should all be thinking about as we think about the smart medtech portion. So Jim, you've got an interesting position with Greater MSP and some of your background, so maybe you could introduce yourself and kind of the role that you see Greater MSP playing.
Well, thank you very much, Rick. So Jim Southwick, I'm an executive fellow at Greater MSP. I retired from Medtronic a year ago, and there were a few of us on the way out the door that the CEO invited to engage on a project that was of concern to him and that he's been driving now over the course of this year. And I'll get to Greater MSP in a second, but the roots of this project, in my last half dozen years at Medtronic, I was running our Worldwide Government Affairs program, and I used to have an inside joke with my team. Everywhere the CEO lands, the government asks for a factory and an innovation ecosystem for Medtronic to contribute, and the competition in the world is intense, especially from China, but not only from China, in terms of the efforts to build leading medical technology. And although Minnesota may be the Silicon Valley of medical technology innovation, our Commissioner of Health hadn't been told that yet, and that's sort of emblematic of maybe that's the Minnesota way. I know I heard an old joke, which I hope isn't off color, but did you hear about the Minnesota man who loved his wife so much that he almost told her? And that's kind of our reputation. Although we are the Silicon Valley of medtech, we're not telling enough people. And and the vision from Jeff Martha, the Medtronic CEO, is that although this is the foundation and is the Silicon Valley, we're at a juncture where we need to energize to the next level, build the collaboration, and recognize the global context in which we're operating. And it was a similar thought that the United States government had as it passed the Chips and Sciences Act. Now, of course, competitiveness in chip technology was a central focus of that, but there are a number of technology sectors where the U.S. government was worried about, are we keeping up our global competitiveness? And medical technology is one of the named areas. So those factors aligned, and Jeff was looking around for a venue and an organization to help drive this project of increasing the coordination, collaboration, and focus. And Greater MSP emerged as the venue. It's a very unique organization. It's one of our little-known gems in Minnesota. It's a public-private partnership, an economic development organization for the greater metropolitan area. And its focus and its real sweet spot is in these types of projects that require bringing together stakeholders from around the area and economy, cross-sectoral collaborations. And so I've been extremely impressed, actually, with the staff and the talent and the leadership at Greater MSP, how they have driven and taken on the lead of this project. I think it was, Dawn may have mentioned, the current status is that in October, after the first round, we were named one of the 31 hubs. That came with $0. That came with the prestige of saying we are named as a tech hub officially by the United States government. The real action was February 29th, when we submitted the grant proposal for about $60 million, with about $65 million of private matching commitments from what are now 40 organizations involved. So of course Medtronic, but there's very close collaboration at a CEO level with the Mayo Clinic, with Allina Health Partners, and with Bobby, and with the University of Minnesota, with the governor's office, and with community organizations and organizations focused on equity, on the investment community and startup communities as well, to build this kind of momentum and collaboration. So it's a wonderful project. We had the Commerce Department come visit virtually, I guess, couple weeks ago and ask us questions. We had all the representation around the table, and hopefully there'll be an announcement on the award within the next 1 to 2 months. The CEOs met, and Bobby was there, I think, a week or so ago, roughly.
Week ago Friday, yeah.
And I think there's a desire, which she can speak to better than me since she was there, that one way or another, at least some aspects of this project need to go forward, grant or no grant, from the Commerce Department. So it's a very, very exciting project. And I want to do one more quick thing, which is I think we saw some fantastic examples of the power of AI and the convergence of AI and medical technology from the sort of administrative efficiency and provider efficiency point of view. I want to give you one care example. It's surprising, it's a Medtronic example. But there's a lot of advancements with AI med tech in the area of improved diagnosis and treatment, and not only making it better and faster and more precise, but easier and more accessible in a simple clinical setting, which goes to some of the equity considerations. So Medtronic has a product that is AI trained to help a GI doc read a colonoscopy and identify polyps. And it was trained on 13 million images of colonoscopies. And what it does, in the middle of the colonoscopy, while the scope is on screen, little green squares appear and say, look here, look here, look here, for the polyp. And the clinical evidence says this is improved polyp identification by 25 to 50%. Now it's been well documented. And colon cancer is the #2 killer. And if you can diagnose early, you can prevent it. And there's a major healthcare savings in better treatment, more precise diagnosis. But that technology, this is why the collaboration is needed. Where do you get 13 million colonoscopy images if you're a startup entrepreneur and you want to train your AI algorithm? It's hopefully all on Epic, and so it's at least electronic, but it's not scrubbed, it's not curated. What are the legal terms? How are you protecting privacy and security? What are the arrangements? That's a major, major obstacle for an entrepreneur to get over. And one of the exciting things about this collaboration is one of the 5 main projects is to build the North Star Data Alliance, which is a collaboration around data access for smart med tech research. And we have the Mayo Clinic, which has a fantastic data system it has put together with its global. It's not just their lead headquarters in Minnesota. They've got all their global clinics and a system to enable access for research. The University of Minnesota, same thing. So we have 2 major healthcare systems that are being prepared and curated, where the hub will prepare the role of concierge service, of especially what are sets of terms and conditions, the legal hurdles for an entrepreneur to even, where is the data, how do I get access to it, and how many years am I going to have to negotiate with Mayo in order to be able to get access to the data? If we can standardize and systematize those things, we're going to greatly enable innovation. That's just one of the examples of the project. So, Rick, I've gone too long. I'll stop there.
That's all right. Thanks, Jim. And I think a lot of what we're getting through here today are giving a little bit of background on the initiative, but also really peeling back and looking at how it really requires a village. It requires a large set of cooperations to make
Yeah.
these things happen. And so as part of the proposal, as Jim's kind of hinted at, we have a data portion, North Star Data Alliance. We have work to be done on what we're calling incubation, and we'll talk about that in a second. We've got workforce, so there's a bunch of work going on to make sure that we have the workforce to support this. We're also looking to be the host of lots of other companies that want to come to Minnesota to interact with that ecosystem and get that support. And we're also looking at bringing additional investment. So there's a capital element, there's a diversity, equity, inclusion element. So there are a lot of different elements of this proposal, and it has to all be pulled together. And, again, it's going to be very helpful to get the money, but just all of the conversations, the journey we've together made to get to the point of putting this proposal together has been monumental. And I think, quite honestly, part of it happened because companies, Jeff Martha at Medtronic and other companies leaned in saying, this is important enough that, yes, we may be competitors on some of our tools and technologies and products, but for the betterment of patient care and for making this community stronger, we have to cooperate. So one of the things that is important in this MedTech 3.0 proposal that really speaks to the collaboration is a portion called incubation, and working with startup companies and companies that may want to join or move to the Twin Cities or the Minnesota region. So maybe Bobby, could you talk a little bit about this Incubator project and how Medical Alley can participate and how you see this coming together as you've joined the MedTech 3.0 proposal?
Absolutely. Excuse me. The incubation is actually, once again, it's a cooperative of groups coming together. So Launch Minnesota is part of it. Think of it almost like a roadmap of where it's come one, come all, in terms of attracting entrepreneurs and folks interested in smart med tech. And they'll funnel through as the original Stage Gate 1 through Launch Minnesota. And then from there, Stage Gate 2, they will hit Medical Alley. What will they find when they hit Medical Alley? They'll find our STARTS program, which in 1 year alone, just this last year, we took care of or serviced and provided programming to over 1,300 startups from around the world. And within that, then had some placement and matching with capital and investing and mentors and entrepreneurs finding a sense of community, and equally important, finding the connection points that they need in order to move along a total product life cycle. So as we know, in healthcare, there are a lot of different components to consider. And lots of times when a physician comes in or an engineer comes in, they know really well what they have in mind, but they aren't necessarily thinking about that whole, I'm going to call it environment or ecosystem that touches them as they're starting to start a company. And so we bring in FDA advisors, we have access to CMS, because if you're not thinking about upfront, am I FDA going to have to be classified or go through the process? How does that impact my reimbursement? If you can't get the product paid for, it doesn't matter what you create. We have to help you be able to figure out that that problem or solution sooner rather than later. And then from there, we move into traditional coaching and mentoring around the subject matters you would expect in a startup. So what's the problem you're solving for? How are you going to bring it into the market? What's going to be the receptivity? What does your workforce look like? What are potential partners? Financing? How are you going to pitch it? And hopefully then get some momentum in terms of what you're doing. I say that, but also recognize that Medical Alley Starts Today also has the ability to take companies at different stages. So we take everything from the solo entrepreneur who's just got an idea and is looking for a sense of community and learning, to mid-stage to Series A and Series B, depending what they're seeking when they find us. That's the programs and services from Medical Alley's perspective that we will offer through this incubation period. We've then been charged to create a list of 25 to 50 that would move to the next stage gate, which is when it moves into the University of Minnesota and Fogarty's work with the ideal of taking a cohort ultimately with the Fogarty program of 3 to 4 candidates per every 6 months, enroll it, so it'd be about 8 a year. What it takes from our standpoint is collaboration by all parties, and we have a history of doing it. In actuality, we've been doing variations of this for almost 40 years. It was part of why we were developed. So Medical Alley, if you tear back to the roots, is about economic trade, development, workforce, and innovation in the healthcare sector. And so we're applying that for this program through STARTS, and I see no reason why it won't be successful.
Right, thanks, Bobby. And I think it's an example of taking what we're already doing in some shape and form and just really focusing it on a specific problem, but focusing on it together. And I think that that's the power, the whole is greater than the sum of the parts. So one of the elements which we talked a little bit about is the data element, and Dr. Cunningham, maybe you could talk a little bit about data and kind of the ways you use it, but possibly some of the data that the state and your department has that might be useful in this endeavor.
Yes, thank you so much. So one of I come from the U. I was a professor in the medical school before I switched over to the Minnesota Department of Health. So my background is as a researcher primarily. I care a lot about data. There are a lot of initiatives going on right now supported with a lot of federal dollars, mostly around data modernization. Part of that stems from us having to come in and create new systems to respond to the pandemic, right? And some of our key partners include our big healthcare systems who came together through the Electronic Health Record Consortium. And so our COVID data that you find on our website, for it to be timely, for us to be responsive, required the partnership with the big systems. And it's 10 or 11 systems across the state and Hennepin Healthcare is the group that sort of puts the data, aggregates all of the data together. I will say there are a couple of major challenges in the data space. There's so many challenges in the data space. What I would say for us as a department, the conversations that I have with our team are traditional historical public health methods rely on things like surveys. And at the best, our survey might hit 15,000 people, 15,000 Minnesotans. Minnesota has 5.5 million people. The Electronic Health Record Consortium covers, their website says they cover 90% of Minnesotans. So we need, I foresee, I can't think that it's anything but inevitable, right, for public health. And when you look at what's coming out of DC from the Office of the National Coordinator for Health IT, they are thinking this way as too, right? Our clinical data systems need to be built out in a way that thinks about and collects rigorously high quality data, not only about people's conditions, because that's some of the challenges when I talk to my teams about clinical data is it quality data? But quality data about people's conditions, right? But also quality data for me as public health about the lived environments and the communities from which people come from, right? And so we're doing a big geocoding project, but healthcare, if it's covering 90% of Minnesotans just in this one partnership, what are those sort of geocoding projects, or how can we come together, right? And there are all sorts of logistical challenges and data privacy challenges in doing that, but we have to do that because it is from receiving timely data from healthcare that public health will be able to be more effective. There are a number of other data challenges. We've already talked about AI. You all know all of the inherent risks in terms of bias being built into algorithmic models for AI. We really, really need to be mindful and think about that. And then in addition to data sharing from healthcare to public health, we have to think about data sharing again to people and to communities, because our strategy, and when we think about equity, is to really hear communities' priorities, talk to folk, and hopefully get to community accountability, community co-design, so we know what will work for people in their real context. You know, for me, coming from medicine, we talk about the clinical trial, right? And then we talk about the pragmatic clinical trial, like when it really hits the real world. And so without community engagement, you're going to also miss that piece.
I think that's great. Go ahead, Jim, you have a follow-up.
Yeah, sorry, I just wanted to actually speak a minute to the equity point because it's so important in this, and it is also a crucial part of the MedTech 3.0 hub strategy. It is one of the key project areas with a dedicated team, and I think the thinking about driving the equity in the project is look at it in several different ways. I mean, first of all, this is an economic development project, and so part of it is conscientious focus on the participants in the economic development, not from a workforce development point of view, but also engaging the entrepreneurial community for folks who have been had less access to resources to be able to bring forward their ideas. And there are very specific plans about how to, from the entrepreneurial community to engage as well. But then there's also, I think, an important aspect about what are the investments and technologies that are being developed, and is equity a lens in disease states and in therapies and treatments and applications that are being developed in the project. So there's a strong sense, I think, that Dawn conveyed that technology, innovation in and of itself needs to be directed at something to be part of the solution, and equity needs to be a conscious part of the innovation model, and I did want to emphasize that it's on the minds and a core part of the strategy.
I would add to that by saying, so when you were referring to the meeting of the CEOs a week ago, there was a commonality. It was interesting, we did a vote in terms of what people's interests and priorities were. Mm-hmm. And the number one thing came back to data, but the underlying premise of the interest in the data was around patient outcomes. So at the end of the day, when we talk about access, equality, affordability, the way we impact those things is by knowing what those outcomes are. And by knowing and understanding those outcomes, we're able to tweak the direction we're going. And I was thinking of Don, when you were even talking about value-based healthcare. And we talk about, from a value-based healthcare perspective, how do we drive then pay for performance or a premium side, which is what I did at United Health Group when I worked there. But it comes down to, and when I was at Medtronic, it comes down to real world data, real world, real time, looking at people's living conditions and the entire component. And that very much is a piece of this work.
And the last thing that I would add about the data space is I would add maybe two things are health systems really have really challenging problems about disparities in outcomes, right? And so even once people get into the system, right, we can liberalize and think about ways to get people into the system, telehealth, all of these platforms, which are fantastic. But even once people get into the systems, care opportunities are going missed. Not everybody is getting the same standard of care once they come into systems. And healthcare entities are really wrestling with that. But an invitation that I would say to this audience is, how do you work with healthcare partners when they're looking at methods to improve their quality of care? What is the platform that helps them lift up the patterns that they can see, right, about how patients with different lived experiences actually get differential access to care? And how can we flag that so that people don't go missed? And how can we also think, when we think about community health, big things like infectious disease, the opioid epidemic, and community prevalence of conditions, how can tech, again, go a bit from med tech to health tech, right? A bit from what's happening in healthcare and clinical environments and a product for a patient, to products for communities, right? Particularly around these things that are community violence, again, infectious disease, opioid epidemic, like what are the tech solutions in these spaces?
Well, and a key differentiator, I'd call it that too, and we talk about smart med tech. A lot of times it is natural to immediately think about that in terms of an implantable. And that is not necessarily the case here. So we also have to think about that full spectrum of what we're seeing in terms of even like what Don was sharing with these companies. Those weren't necessarily implantables. And when you talk about the invisible room, you look at Lake Nona, Florida, the work that they're doing down there with Deepak Chopra, where there's an entire community that's invisible and participating in that. So that's another thing to keep in mind, just even with the titling of this project.
A lot of great observations. I think one of the things I like about panels is you can never predict which way it's going to go, and it's been a very, very good contributions. One quick question, it's a little bit of a segue into a different topic that I want to ask before we give the audience a chance to ask a couple of questions. So one of the premises, not just of this panel session, but of the whole MedTech 3.0 effort is that corporations are actually going to work together. And many of us have worked in corporations on the panel here and know that that's very atypical. You don't usually share your plans and your missions and join together. You know, maybe, I don't know, Bobby, Jim, either one of you have any observations on how you see this being different, not just the why we have to do it, but kind of some of the key learnings or things that you've noticed in the past 6 months in working on this effort with corporations, either one of you.
I'm going to just back up and say, when I think of Minnesota, and I'm born and raised here, spent my entire career here, and I've worked in all sectors, payer, provider. I've worked in med tech and most recently private equity before coming to Medical Alley. This community knows how to rally and come together when there's a problem to be solved. So as a native Minnesotan, I will say that what I'm watching isn't that unique to what we do, particularly in healthcare. And I think what's happening is what we saw today in the earlier presentation by Don, which is that an environment is coming together with some critical factors. There's number one, the increasing cost of healthcare, which we've been watching my entire career, and we've paid a lot of lip service to it, and it isn't until we get into a regulatory situation or a crunch that we react. It seems to be a bit of human nature. Number two, what we've been seeing is that there is the government right now putting together through CHIPS bill. So we were at the table. A huge part of our work, which I didn't mention, is policy and advocacy. We're well known for it, both state and federal. And we were at the table when the CHIPS Act was being put together. And so as we see that, we see a convergence of industry and interest around that. And then third, what we see is as a result of that availability and this interest from leaders in the community, driven by Jeff Martha. I mean, Jeff had a call, he pulled out, he rose his hand and he said, it's time. And people rallied, the university rallied, the state rallied, Greater MSP rallied. I mean, that original application had 7 of us at the table. We wrote the life science section. And now, as you mentioned, you know, there's over 200 people and double that around the table on the CEO part. So I'm not surprised by that collaboration, and as we watch it mount to over 200 people that step forward on the second round, I think our biggest challenge is going to be to stay focused. I think our biggest challenge is that we had a goal and the purpose statement around this work, and now it's taking it and funneling it and actually being able to have a critical pull-through on what we say we intend to do. And I think the other challenge is if the funding isn't received, what does moving ahead with it look like? It's one thing to say it, it's another thing to do it. And if the funding comes through, that becomes more clear. It's my personal
Yeah, Rick, I would just add a couple, fully agree with everything Bobby said. When the Commerce Department came, the EDA came and visited in the virtual site visit, they were supposed to just be asking questions and listening and not giving us any feedback. But privately to our lead organizer afterwards, they did privately say, you guys really know how to collaborate. And it is true that is actually part of our pitch, or a central part of our pitch. It's one of the key things that is needed in order to actually get this ecosystem to the next level. A reinvigoration of the collaboration is a central part of the pitch.
And you know the cool part about Minnesota on that also, it's one thing to collaborate and everybody comes to a table and there's active listening and people want to contribute, but the core part of that is this community is courageous, because at the end of the day there are others who are willing to step back and say, you know what, you can do it better than me. So you go ahead and let me know how I can support you. And that happens in this community every day.
And please don't forget the public-private partnership. And I say that because when I go to national meetings, you know who is showing up in the public health meeting? Google is showing up in the public health meeting, right? Like Amazon is showing up in the public health meeting. And so let's do that here also, right? In the Silicon Valley, let's think about when and how public health can come and be a thought partner at the table too. Public-private partnerships are incredibly important. Public health, again, for the ideas, the creativity, the brainstorming, the troubleshooting, but also population health is a team sport, right? Everybody has to do it, and we need that support. We need the support from the people here, the people that you all represent, to help us do public health better. So just one plug as we're talking about partnerships, about don't forget the public and both state and local public health for innovation. Thank you.
Totally agree. Thanks. Thanks for that. Questions? Anybody in the audience? Go ahead.
Thank you for the presentation and for covering the different aspects. I'm excited about the potential of this collaboration. Had a chance to be a part of the review. Thank you for the submission. I'm actually a nurse engineer, so I've spent 20 years in biomedical engineering doing med device development, and I ended up going into nursing because we just never quite got it right. We started this talk about the EHR, and if you really start digging into that, there's a lot behind that. And I would be interested to know how many people in this room are representing care delivery, because what I have found is that they're too busy. They don't have time, and they don't have space to think about these things. There was also some mention around, change management and things like that. So my question to this panel, and I was on a very big call yesterday with a bunch of clinicians looking at healthcare transformation, and they posed the question, as a country, do we want a healthcare industry, or do we want a healthcare system? And they're two very different things. And what makes me really nervous about the MedTech 3.0 and the use of smart technology is, what is smart? And who are we putting at the front of these voices? What are our requirements? What are the goals? Are we trying to achieve a vibrant economy where we continue to make money off of health? Or are we even going beyond and asking, is there room for new business models? How can we all be profitable as a country, as a planet, as a world? And I think if we don't have care delivery voices and patient voices at the front of that, we cannot be successful. The pumps don't work like we want them to work. Right. The implants don't work like we think they do. I was part of those development projects. And we just need to bring all of our power and our voices together. So I would like to hear what you guys think about that around being an industry versus a system, and how do we put health, like people's actual health, at the forefront?
I totally personally resonate with what you're saying, and actually when you look at some of the work that Medical Ally does, we include patient advocates. And I'm a faculty advisor to this day on post-market surveillance for the FDA, and if you were going to give them credit on one thing, it's that they've started in the last decade putting patient advocates for just the reasons you say. Because it's one thing to come around as engineers and design something. It's another thing to be the patient actually using it and living with it and paying for it. And so a lot of the work we do does involve the public. And so I understand what you're saying. How do I see it? I see it as a system. It's an industry in terms of how we talk about it from an economic component. It's a system in terms of what I said earlier, of thinking about a continuum of care and all of our touch points on it with one at the center. So I used to be the chief operating officer of Abbott Northwestern. When we talk about care, we talk about the patient in terms of being at the center of that care. Great. That's how we see it.
Richard, did you want to add? I just want to add a couple of comments. First is, I really want to reflect where Dawn steered us in the opening, which is innovation in and of itself is not a worthy goal. It's to innovate to accomplish something else, to improve healthcare, to improve the patient outcomes, to improve the efficiencies and burdens on the clinical providers. Those are the goals. And innovation needs to be part of achieving those goals. But it needs, and I think the core idea behind this project is exactly what you're saying, is in order to do that, we actually need the system together. We need the collaboration. So we do have many of the major provider organizations headquartered in Minnesota, and we, of course, have huge nationally, organizations of national scale that are active members at CEO level of this organization, of this project. But the community voice is also crucial, and the government voice. And the governor's office and the workforce teams have been extremely active and leading, actually. The workforce, the talent development is actually being led by the state in terms of project leadership. And a strong focus on who are the community health representatives, as well as the entrepreneurs who will see and have the ideas about solutions particularly needed out in the community, and to make sure those voices are part of what's in the strategy. And there are many sort of micro pieces about it, many tactics about how you're going to find those projects and pull them into the system and get them some support. So fully support your comment and agree it has to be a system approach.
Oh, the last thing, I was just nodding because you said not only sort of the community connectors, but the entrepreneurs, right? Because one thing that I say in this role is that, because we do a lot of community engagement, right, is that we will hire Black and brown people all the time to go talk to other Black and brown people. But where are we hiring Black and brown people for their talent, their genius, their intellectual capital? And so I appreciate the community entrepreneurs comment. And as I see, we're gonna close. If y'all could also get into the dental space, please do. Folk who are Medicaid in particular have a huge challenge in accessing dental care. So if there is some technology that you all can develop for oral health, please do. Please do.
Very good, very good. Well, please join me in thanking our great panel this morning.
Rick, Bobby, Brooke, and Jim, thank you. What a rich conversation you have. We really appreciate it. We're going to go to a break in 1 minute, but I just want to wrap up by, I love to sort of listen to a panel and try to put some thoughts together as we transition. And Brooke, I was really struck by your strong request to look at public-private partnerships, including public health, and integrating with clinical health. And I'd like to remind everyone that this thing we went through called COVID, the accomplishments that we had across the nation and across the world only happened because of the combination of the traditional public health system and private industry. If it wasn't for UPS and FedEx, those vaccines wouldn't have been where they needed to be when they needed to be there. And we have so many more examples of that. So I hope we learned some lessons from that as we move forward in how to leverage AI and how we improve the healthcare system. And I want to just end with saying, I loved the question of saying, what is smart? Let's start with a definition of what is smart and then build to that. So with that, let's take can we do a 5-minute break so we can maybe get sort of back on track and be back by a little after 10, 11:10, I'll give you till 11:12, okay? Thank you so much. Thank you. Sorry, I had to cut it off.
That's good, that's good, thank you.
Okay.